Hello, my name is Carmen and I'm speaking to you from Lorente Orthodontic Clinic in Zaragoza, Spain. I would like to thank the journal for giving us the opportunity to present our study, and with this video I would like to introduce you to the miniscrew supported pole technique. This surgical procedure has been used in our clinic to force the eruption of impacted or retained maxillary and mandibular second molars when the patient has at least 3 of the following indications: older than 14 years old, vertical, distal or mesial molar angulation higher than 45 degrees, severe bone depth of the molar, proximity to the inferior alveolar nerve canal or the maxillary or mandibular cortical bone, closed apex, alteration of the root apex, previously unsuccessful conventional surgical exposure, and signs of primary molar retention. To perform surgery, the following steps need to be done. First, a splinting wire is bonding to the 3 adjacent teeth with a step between the first molar and second premolar. Next, a miniscrew is inserted in the interradicular space between premolars. Now we can start the surgery. A flap is elevated and part of the bone is removed. Then an attachment is bonding to the molar. After the bonding, the pole length is measured and connected to the bonding attachment. Next, the pole is inserted through the step in the splinting wire and activated by attaching it to the miniscrew with 0.012 inches stainless steel ligature wire. Finally, the mucoperiosteal flap is replaced and sutured. This technique requires only 1 miniscrew located mesially and just a single activation the surgery day. Although only one activation of 150 to 200 grams is required at the time of surgery, the patient should be checked every 2 weeks until the molar erupts in the oral cavity. The selection of the pole length will depend on the angulation of the ectopically erupted molar. Vertical molar position requires a pole length equal to the distance between the surgical attachment and the miniscrew, in order to generate movement in the occlusal direction. A mesially angulated molar requires a pole length 3 mm greater than the distance between the attachment and the miniscrew, to ensure that the point of force application remains distal to the center of resistance, generating an extrusive posterior rotational moment. A distally angulated molar requires a pole length 3 mm less than the distance between the attachment and the miniscrew, to ensure that the point of force application remains mesial to the center of resistance, generating an extrusive anterior rotational moment. In this study, during a 2-year period, a total of 21 patients with 24 retained or impacted second molars were recruited. 13 molars were maxillary and 11 were mandibular, among which 6, 25% were impacted molars and 18, 75% primary retained. Before treatment, the molar angulation was mesial with more than 45 degrees in 6 molars, vertical in 13 and distal in 5 molars. More than 80% of the molars had a severe infraocclusion degree. The period of eruption after surgery was approximately 4 months. Only 3 third molars were removed due to lack of space. The anatomical radicular alteration was the only variable independently related to a longer time of treatment. After treatment, all second molars managed to erupt, achieving a success rate of 100%. So in conclusion, the miniscrew supported pole technique seems to be a safe and effective orthosurgical technique to force the eruption of impacted or retained second molars with any type of angulation and location. To see the full details of our study, we invite you to read the article. Thank you very much for watching this video presentation.